is very humbling to give a talk of vaccine and immunologic response in a session where Dr. Anthony Fauci is giving the keynote address, right? Since he is the ultimate expert on the subject, and I will just give the neurologist perspective on the topic. So first, to talk about the immune response against the virus, they are, two major arms of the immune response, the one that's mediated by the humoral immune response or B lymphocyte that produce antibody against the virus. And those can be detected by serological tests, which unfortunately are not very sensitive. And the first one that was on the market that was produced under emergency use authorization by the company Abbott was looking for antibodies against the nucleocapsid protein of the virus, which turned out to be not as sensitive as the newer test looking for antibodies against the spike protein of the virus. So that explained the fact that some people at the beginning of the pandemic tested negative for antibodies using the first test, right? And therefore had the same exact symptoms of long COVID as those that tested positive, but they could not be categorized as COVID-19 for those reasons. In addition, some of these patients tested also negative by the nasal swab because they had only mild respiratory symptoms that went away, like cough, sore throat, a bit of fever, muscle pain, but that went away. And oftentimes they could not be tested by nasal swab to look for the virus RNA by RT-PCR because it was not available to them since they didn't have pneumonia. And if they got tested after those symptoms subsided, they did not check the virus anymore, so they were negative. So there's no real gold standard for diagnostic testing for SARS-CoV-2. That's the major point, that I want to come across because of the limitation of the test and the fact that people may not be shedding the virus permanently or that they have a low antibody level in their blood to begin with when they have mild disease. So that's point number one. The point number two is that we're trying to figure out what is causing the neurologic symptoms of non-hospitalized long haulers, including brain fog, headache, dizziness, and disordered smell and taste by looking at their T-cell response against SARS-CoV-2 protein, because we think that there's a dysregulation of this T-cell response in those patients that lead to a confusion of the immune system that now thinks that something is abnormal in the brain that needs to be attacked, which is not the case in those people who get infected by the virus, but then remain completely asymptomatic thereafter. We also hope to detect why some laboratory negative long haulers may have been exposed to the virus by looking at their T-cell response in their blood, because we can interrogate those T-cells and they can tell us, since they have memory, if that patient has been exposed to the virus or not. In terms of vaccine, there are many different vaccines that have been rolled out in various places in the world, and some are mRNA vaccine, some are adenovirus-based vaccine. Some require one shot, some require two shots, various cold storage necessities, and also vaccine have various level of efficacy, but you have to understand that they were tested in different places in the world, sometimes at different time in the world, and those vaccines that were tested in places like Latin America, where there was already some variants around, right, are not expected to have exactly the same efficacy as those that were tested only in the US, where there were no virus variants at that time. But all vaccines have shown some protective effect, a very important protective effect, but not to prevent infection completely. The protective effect has been shown also in patients who get infected, so they have milder disease, and there is less hospitalization in patients who are vaccinated, and also much less severe disease and great decrease or a total suppression of a number of deaths. Proof of the pudding, in a sense, is what's happened when a large number of people are vaccinated in a specific geographic area. And the success story that I talked about is the one of Israel that has vaccinated very quickly about half of the population of this entire citizen, and showed that there was a protective effect for all those categories in the real life setting. And since they vaccinated the older people first, above 60 years old, then they could see a difference between the older 60 and the younger than 60 in their population, showing that there's a real vaccine effect also at that level. We have vaccinated to date about only 16% of the population in the United States, although vaccinating like 3 to 4 million people every day, which is still remarkable. And we are in a race with the virus between the effort of vaccinating the most number of people, the biggest number of people to achieve this herd immunity, and the virus that wants to mutate away from the protection of the vaccine. And we already have, the UK variant and the Brazilian variant and the South African variant, and there are some variants arising all the time. And you can follow them on the CDC website. You can see where they are in the population, or in geographically. And there's still some unknown whether those variants are going to lead to a different clinical presentation. So we see already, unfortunately, that younger people, get infected by those variants because there's a COVID fatigue, and people are not paying as much attention with social distancing and wearing masks. And now we see that the younger people between 30 and 40 years old, are the ones who are getting infected and hospitalized instead of the 50 and 60 years old like we had before. So far, what I understand is that the vaccine are still protective, against those variants, but there have been some complication of some vaccine, like the AstraZeneca in Europe, with some events of thrombosis in young people or younger people leading to death, although it's still 1 in a million, I think, in the population, but it's still, worrisome and cause of concern. In the meantime, I think we need to follow the guideline of the Center for Disease Control, at least here in the US, and the people who have access to the vaccine should get vaccinated with whatever vaccine is available to them at that time, which may vary because of distribution and geographic location and so on. Because it's still, even if they've been infected by the virus in the first time, we've seen many cases of reinfection with the virus, and we hope that the vaccine is going to be more protective than just being naturally infected. These are the recommendations so far. We are not out of the woods. Unfortunately, there are some societal issues that are against vaccination. The Catholic Church, unfortunately, came against the Johnson & Johnson vaccine because it said that it was immoral vaccines. It was in part developed using embryonic kidney cell from a fetus abortus in 1970. And it's unfortunate since the Johnson & Johnson vaccine is only one shot and doesn't need more than 4 refrigeration lower than 4 degrees. So it would be the most available and to disseminate in limited resource setting, which is the most needed at this time. And there are many anti-vaxxer movements in the US and also in other places in the world where people really don't want to get the vaccine, which may preclude reaching herd immunity in those geographic locations.